The record message come.
Yes.
Okay, so good evening. Welcome to this session of ISG PG Clinics. We are having a recent advances series. The first one is on recent advances in hepatology. The second one is on gastroenterology, and the third one is on endoscopy. These sessions have been planned in such a way that the exam-going students will benefit from these sessions because our experts will go through the recent advances and prepare the slides and actually save the time of our students. Otherwise, they have to go through all the journals and read a lot of articles. But our experts actually do the job for them and we present to them in a nutshell, so that it will be extremely useful for our students. For today's session, we have Dr. Cedric Abby Phillips, who will be formally introduced to you. Welcome, a warm welcome, Dr. Abby.
Thank you, sir.
The chairperson for today's session is none other than our beloved Shanai sir. So I am very happy that two avid researchers are on screen, one senior person and one young person. So it's a good combination. So over to Shanai sir for introduction of our speaker as well as to continue the session.
Thank you, Dr. Varghese. It is always my pleasure to be with the Indian Society of Gastroenterology, Kerala chapter PG meeting. And I am privileged to have one young and bright star, Dr. Cedric Abby Phillips. He is actually the proud son of India, representing India in the hepatology meetings globally, has won many awards as the young investigator, the young scientist, and probably as the best orator in most of these meetings. Dr. Abby had his post-graduation at ILBS with Professor Sareen, and he has proved himself worthy of the position by having more than 200 to 300 publications in privileged and highly indexed journals. Dr. Abby is currently the senior consultant in the Liver Institute at Rajagiri Hospital, and he is also running a busy research unit focusing on microbiomes. The next 40 minutes are with Dr. Abby to give us a glimpse of what is happening in hepatology under the different sections of basic hepatology, clinical hepatology, translational research, and many more things in the next couple of years. Dr. Abby.
Thank you for the kind introduction, sir. I hope I am audible well.
Yeah, very well. Welcome,
So,
Jayanti ma'am also. Welcome to Jayanti ma'am also, who is the other moderator.
Dr.
yes,
Jayanti, welcome.
Proceed.
yes, sir. Thank you for this opportunity to present this very important topic. And as always, it's a pleasure to teach the students. And I think this is the most important part of specialty training. And thank you to Professor K.T. Shanai sir for the introduction, and to my moderators, Professor Varghese Thomas and Professor Jayanti ma'am. So without much delay, I would like to start off with the first topic. So this is going to be a different kind of presentation because I am not going to bore anybody here. I have chosen topics randomly and I'll be presenting randomly so that people don't get bored. So I don't want to show you continuous fatty liver disease studies, continuous alcohol liver disease studies, but I'll just mix and match so that it will be fresh in the minds of everyone who's listening. So the first study that I would like to present is this. It's a very important position paper. It's not actually a study. This is the paper which changed the terminology for NAFLD and NASH to MASLD and MASH. So this is by the consensus societies of ASLD and EASL. So what they found out was that when we use the term non-alcoholic fatty liver disease, it has negative connotations. For example, when you say non-alcoholic, it's stigmatizing. And when you say fatty, it's even more stigmatizing to the person. So we do away with all of that, and we now call it as steatotic liver disease. So that is SLD. So it's no more fatty liver disease, it's steatotic liver disease. And that is either identified on imaging as steatosis or in a biopsy. Now, if the patient or a person has specific features, which is given in these boxes, that is adult criteria and the pediatric criteria, based on the presence of 1 out of 5 in any of these particular factors given, you call them as having metabolic dysfunction associated steatotic liver disease, that is MASLD. If these patients have metabolic dysfunction along with less than significant amount of alcohol consumption, then you call it as MET ALD, which is metabolic dysfunction with presence of alcohol use. And at some point when there is significant alcohol use, we call it as ALD, that is alcohol associated liver disease. So there are other causes also for steatosis, not just metabolic syndrome. So then we have patients with specific steatotic liver disease, like for example, certain drugs can cause steatotic liver disease, for example, corticosteroids. There are certain monogenic diseases that is, for example, in Wilson's disease in children, you can have a fatty liver. So that will become a monogenic liver disease, which has a steatotic component. So it's a very, very simple way of describing steatotic liver disease based on the criteria. Now, what is the spectrum? So you have metabolic dysfunction associated liver disease, which is MASLD. And on one side, if you actually look at the second box here, you'll see that these numbers 140 by 210, and at the extreme is 350 by 420. So that is the weekly amount of alcohol intake in grams. And if you go down, you can actually see the daily amount of intake, which is 20 grams in female, 30 in male. On top is 140 in female, 210 in male. So weekly, if it is this much, and daily, if it is this much in males and females, then you can club them under MASLD, which is, there is no significant alcohol use. So it is metabolic dysfunction associated steatotic liver disease. Now, if the patient is on higher amount of alcohol use, for example, in women, 50 grams per day, or in men, 60 grams per day, then that is the ALD predominant. So that becomes MET ALD. So this is MASLD and this is ALD. Now, if they go beyond this, that is beyond 50 and 60 or beyond 350 and 420, that goes to ALD. That is alcohol-associated liver disease. So this is very easy for us to make patients understand regarding what kind of disease they have and what are the factors that we need to modify in them. So it is no more NAFLD and NASH. It's not easy for us to directly jump into these terminologies in the practice because patients may not easily understand how this change has come into being. But at least in your documentation, please use these terms, because at some point this has to become the standard of discussion on steatotic liver disease. Now, the second paper I would like to showcase is the Liver Hope trial. So this is a very important trial, and this is not published yet. So I've taken some studies that have been recently discussed in ASLD and EASL also, because this will become publications later on, maybe in the next 3 to 6 months. But it's important for us to know about it. So this particular study looked at patients who are on statins. That is, they gave patients 20 milligrams of simvastatin along with 1,200 milligrams of rifaximin, that is 400 mg TID, for every day for 12 months. That is about a 1 year. So these patients are decompensated patients, and they looked at how many of these patients actually go on to develop acute and chronic liver failure. So this ACLF is defined as per EASL. For example, there is single organ, double organ, or triple organ failures based on EASL. So based on that, when they looked at patients who were receiving the treatment versus the patients who were receiving placebo, they found out that there was no association with reduction in ACLF or complications of cirrhosis or death with simvastatin and rifaximin, which means the combined use of statins and rifaximin did not improve any outcomes in patients with cirrhosis with respect to ACLF development or other complication of cirrhosis and death. So this was a negative trial, but I think it is very important because there are specific groups where this may be useful, but at the moment, with regards to ACLF, this is not very useful. The second is this very important study where they have actually shown the importance of natural history in alcohol-associated liver disease. I think this is something that we need to really look into. So imagine somebody comes to you with a diagnosis of chronic liver disease, and he's been consuming alcohol heavily in the last many years. and you evaluate the person. And obviously, we do a fibroscan or a shear wave. That is now a standard that we do in most of the centers. And you get a fibroscan saying it is F0, F1, or a fibroscan that says it's F2, or it says F3 to F4. Now, what does this mean with respect to what the patient is going to face in the future? Very importantly, this study has found out that when they followed up these patients with recently diagnosed cirrhosis or chronic liver disease due to heavy drinking, they identified that when they were followed up for about 6 years, about 15% of them progressed to decompensation. And this is very important because even after stopping alcohol, or in those patients who were not drinking so heavily. So that particular data is not very clear from this study because it's just an abstract that is published. So when they looked at these patients who have recently been diagnosed with ALD and underlying chronic liver disease, they found out that 15% progressed to decompensation in 6 years. And the decompensating events and the proportion of patients decompensating was higher with the baseline fibrosis grade. So if it was F0, F1, 2% of them decompensated at 5 to 6 years. But if it was F3 to F4, then the number of people decompensating was actually close to 50%, which I think it's quite high. I mean, this is very important because if you get an alcohol liver disease patient who is recently diagnosed and has F3, F4, that means within the next 5 years, he has a chance of 50-50 of getting into a decompensated or a complicated liver disease stage. And most importantly was that about 22% of these patients actually died in 5 years, in 5 to 6 years. And the number of people, person per year, death in 100% years was highest for F3, F4. So this is how the natural history of ALD goes in patients who have recently diagnosed with ALD with past history of heavy drinking. Now we jump to steatotic liver disease, which is metabolic associated steatotic liver disease or MASH. When we have a patient who is recently diagnosed with metabolic syndrome or metabolic dysfunction associated liver disease, we always talk to them regarding control of metabolic complications. For example, control of diabetes, control of hypothyroidism, management of dyslipidemia or weight loss. So this particular study looked at weight loss per se, and this is a very important study because it is a meta-analysis. So they looked at all the randomized control trials that looked at liver fat reduction using an MRI measured method. This method is very important because this method is actually validated. So if there is a more than or equal to 30% relative reduction of liver fat as measured by an MRI from the baseline, that means there is histological improvement, non-alcoholic steatohepatitis activity, resolution of steatohepatitis, and improvement in liver fibrosis stage. So without doing a biopsy, the MRI liver fat method measurement can actually give you a good validation of what is happening at the histological level. So what they found out was that if patients who are, irrespective of the weight, if they did 150 minutes per week of brisk walking. So brisk walking is basically 100 steps in 1 minute. That is 100 steps in 60 seconds. That is brisk walking. If they did 150 minutes of brisk walking in a week, then irrespective of the weight loss, they actually had 3.5 times more likely to achieve clinically meaningful reduction in liver fat, which is wonderful. I think this is such an important data so that people should know that, they should not be stressed and they should not be under stress to lose weight. Just by walking 150 minutes per week, brisk walking, they can actually lose liver fat without losing weight. And I think this should be one of the most important advices that we give overweight or obese patients in our day-to-day OPD regarding improvement in MASLD or MASH. Now we jump directly to an interventional management. So we had a very simple interventional management with walking. Now we go to an invasive management in the form of endoscopic metabolic therapy. So, this is very well known. If you look at the Splendor trial, which was a trial done in cirrhotic patients with obesity and metabolic syndrome, when they underwent bariatric surgery, a lot of these patients actually lost weight after bariatric surgery, and there was regression in non-alcoholic steatohepatitis. There was actually regression in cirrhosis also in some of these patients. So it's very important data that, very important note that people, if they lose weight, they can actually reverse NASH or they can reverse their cirrhosis. But everybody is not very open to going for a surgical management, and surgery has its own pros and cons. So in this particular study, what they did was they did something known as endoscopic metabolic therapy. So endoscopic metabolic therapy is basically they underwent endoscopic sleeve gastroplasty versus they just did an endoscopy, which is like a sham procedure. It is like a simulated intervention. They did not actually do a gastroplasty. That is like a sham intervention. And they compared the significance in weight reduction between two groups with MASH and obesity. Very striking data. You can actually see at the top here, this green circles here. You can see that patients who underwent endoscopic sleeve gastroplasty, they lost 95% of them lost weight compared to just about 60% in the simulated intervention. And they were all on a low calorie diet, a calorie deficit diet. But these numbers are strikingly higher in endoscopic management. Now, when you looked at people who lost more than 10% of their basic weight, that is more than 10% of their baseline weight with endoscopic therapy, they found out that the steatohepatitis score and even resolution of NASH was much higher. So in those patients who you think cannot actually practically in day-to-day life and routine activity cannot lose weight just with dieting and exercise, this is an excellent choice for them to lose significant weight and resolve NASH, underlying MASH. And I think we should not be we should not be very meek in discussing these kind of therapies with our patients, because it improves their life and improves their lifestyle and actually improves or reduces their comorbidities. So for people who are not very well happy or comfortable with going in for a surgery, endoscopic methods of metabolic therapies are a useful modality for improving NASH. This is a very interesting study that was recently discussed in EASL. And this actually shows the importance of something known as SAFE algorithm. So SAFE is basically steatosis associated fibrosis estimator, SAFE. And this is basically a calculator which is based upon the age, BMI, presence of diabetes, platelet numbers, the liver transaminase, that is AST, ALT levels, and globulins, which is total protein minus albumin. And very easy to apply, very easy to use at the primary level, because you don't need to do any additional testing like ultrasound, or you don't need to do any additional testing like a fibroscan or shear wave, because what fibroscan and shear wave does is that it tells you if the patient has advanced fibrosis. So that is basically, it has got a good positive predictive value. And it does not actually tell us any difference between minimal fibrosis or significant fibrosis. For example, F0, F1 and F2 and above, it is not very good, the shear wave and fibroscan. But this particular score specifically looks at distinguishing patients between minimal fibrosis versus significant fibrosis. That is F0, F1 versus F2. And it is very simple to apply. If the score is greater than 100, that means the patient has high risk of fibrosis and needs to be referred to a hepatologist or a gastroenterologist for additional testing in the form of a fibroscan or a biopsy. And this is so important because at the primary level, generalists can or surgeons can definitely identify patients who require further management or further evaluation, and can without any other additional tools with them. Now, something very important. I'm not sure if the students know about this, but there is a huge database on studies on coffee and the liver, and I think this is very important. And it is already well established that drinking up to 3 cups of strong black coffee without any fats or sugars reduces the risk of developing fatty liver disease in metabolic syndrome patients, and also reduces the progression of NAFLD. So this is very, very important. So what this study did was they looked at what is helping, because coffee has a lot of natural chemicals in it, and which of this was helping. So initially the researchers thought that caffeine is the most important part of coffee, but in fact it is not. So both caffeine and something known as polyphenols. So polyphenols are basically the natural plant compounds found in coffee. These include flavonoids, phenolic acid, and also amides. What happens is that the polyphenol and caffeine driven reduction in lipotoxicity and improvement in steatohepatitis actually reduces the risk of progression of NAFLD and reduces prevention of fatty liver disease in patients with metabolic syndrome. So if your patient is a type 2 diabetes with NAFLD or at high risk of NAFLD and who drinks coffee, please advise the patient to continue to drink coffee, which is about 3 or 4 cups a day. And you can actually include decaffeinated also, because some people don't like caffeine. It gives them palpitations and other things. Some people don't feel, they get heartburns and GI symptoms. So those people can actually use decaffeinated coffee, because it's not the caffeine, but the polyphenols that are more important. And encourage them not to add fats, which means no milk, and not to add sugars. Otherwise, the protective benefits will not be applicable. So coffee and the liver, they have a very good relationship. And black coffee actually helps in reducing chances of a progression of NAFLD and reduces the risk of developing NAFLD in patients with diabetes and other metabolic diseases. So now we come to something more interventional, and this is something which is very, very new and recently published. So this is a study known as Maestro-NASH trial, which is a study on resmetirom. So these are the new drugs that you have to know about. Please go back and read the latest review guidelines on the pipeline, the drugs which are in the pipeline for metabolic dysfunction associated steatohepatitis. And you'll see that this is one very important drug. Basically, resmetirom is a thyroid hormone receptor beta selective agonist. So it's a thyroid hormone receptor beta selective agonist, and it is an oral drug, which is it's an excellent drug. It's an oral drug. So what this study found out was that at 80 milligrams and 100 milligrams of dose, NASH resolution was achieved in up to 30% of patients who are on this drug, compared to only 10% who was taking placebo. And this was biopsy proven, and fibrosis reversed, steatosis reversed, lipid functions improved. So such meaningful effects on both primary biopsy endpoints and also disease activity has never been shown in any other drug that we currently use for fatty liver disease. So we don't have such a drug. So this is such an important drug, and I think this would probably receive an FDA approval very soon and quite quickly, because this is the only drug currently in trial practice that we have found out to have effect on both histology and activity in patients with NASH, irrespective of their weight loss or control of metabolic syndrome. So please remember this name. It's known as resmetirom. Now, this is very interesting study, and this came up in Journal of Hepatology reports just this month. So we talk about waist-hip ratio. We talk about central obesity. We talk about abdominal fat, visceral adiposity, etc. Right? For fatty liver disease risk factor, and reduction of all of this actually improves the progression of fatty liver disease or resolves non-alcoholic steatohepatitis. But look at this paper. This paper looked at something very strange. They looked at the thigh fat distribution. So when they looked at people with high thigh fat distribution compared to those with a high abdominal fat distribution, so if they had a high thigh fat distribution, that is thigh subcutaneous fat distribution compared to abdominal fat area distribution, when the ratio was higher, the likelihood of developing NAFLD or the likelihood of remission from NAFLD was much higher. It's quite interesting. The authors have not given us a proper mechanism of action on this. And I could not think from the top of my head how this could actually help in NAFLD. But what they found out was that a favorable fat distribution, mostly in the thigh subcutaneous fat region compared to the abdominal fat, had a protective role against NAFLD. Quite interesting. And the reasons for this is currently unknown, but I hope we'll get an explanation on this in the future. Okay, something quite different from what we were discussing now. And I think this is something that we neglect regarding sleep. So sleep is an important factor in the progression and development of many liver diseases, especially metabolic dysfunction associated liver disease. So, but in this particular study, they did something very interesting. What these authors did was they looked at patients with chronic liver disease and they followed them up, or they looked at their sleeping patterns. So whenever a person had longer daytime napping, so a longer daytime napping means somebody who's napping in the morning or in the afternoon for more than or equal to 1 hour. versus somebody who did not nap at all, they found out that the risk of hepatocellular carcinoma and the risk of death due to liver-related events in CLD was much higher. Just imagine, so simple. Somebody who naps more in the morning versus somebody who does not nap at all, a CLD patient, the chances of them dying and the chance of them getting a HCC is much higher. Similarly, if a person, a CLD person, a patient, sleeps for less than 5 hours compared to 7 to 8 hours, which is considered adequate sleep, or if they sleep for more than or equal to 9 hours compared to 7 or 8 hours, then the chances of them developing liver-related death is much higher. So we're just talking about sleep. And make no mistake, the authors have done a wonderful job because they have adjusted this particular data for age, sex, race, education, BMI, smoking, physical activity, you name it, and even alcohol and diabetes. So it's well-controlled study, and they have shown that it is a U-shaped pattern for sleep and CLD. So if somebody sleeps for less than 5 hours or more than 9 hours at night, the CLD patient, the chances of them developing liver-related mortality and HCC is high. And if somebody with CLD naps for more than equal to 1 hour in the daytime, then the chance of developing higher HCC and liver-related death is much higher. Such a simple intervention that you can talk to the patients and improve their sleep pattern and sleep duration and sleep quality, which will actually improve their clinical outcomes. Now we come to something a little more complex. I put this up because it's come in NEJM, and I think this can be part of your question also on NASH. So this is now mentioned as NASH because this was before the new terminology came out. So this is from Rohit Lumba's team. So Rohit Lumba and Arun Sanyal are the ones who voraciously work on NASH, NAFLD. So what they did was they looked at a new molecule known as pegozafermin, which is actually a long-acting glycopegylated fibroblast growth factor 21 analog. It's tough, but just remember that name, pegozafermin, which is FGF21 analog, which is pegylated. So what they did was that they looked at patients who were at NASH stage F2 and F3, that is moderate to severe fibrosis, and they gave these patients subcutaneous injections of pegozafermin weekly, once every 2 weeks, or placebo. And what they found out was that the patients who received this particular drug, they had a reduction of more than or equal to 1 stage of fibrosis and NASH resolution without fibrosis worsening at about 24 weeks, which is, I think, quite impressive. And those who received placebo, it was only about 2% or so. The other one, it was about 37%. So this is a new drug in the pipeline, which has some potential for treatment of NASH. It might be expensive and it's an injectable. So we don't know how much compliance we can agree with this with the patients, but something new in NASH, because we don't have any proper medications for NASH patients at the moment with us in current clinical management. So we jump to infectious liver disease. So chronic hepatitis D, we don't have much data on this. We don't have much treatment options on it. It's like an orphan disease. I mean, it is actually an orphan disease because this little fellow cannot function without hepatitis B. So the combination of them, that is hepatitis B plus D, is notorious. So they can cause faster progression of cirrhosis. They can cause early development of HCC, a lot of problems. So we needed something to target hepatitis D. And so we have. So this is a drug known as bulevirtide, which is actually a direct acting viral entry inhibitor. So it prevents the entry of hepatitis D virus into the hepatocytes. And this was given at subcutaneously at 2 milligram per day or 10 milligram per day for about 144 weeks. And then compared to a placebo. And what they found out was that bulevirtide actually reduced the circulating hepatitis D virus RNA and completely improved and normalized the ALT levels from baseline, which means this direct acting antiviral has the potential to clear the hepatitis D virus if the patient is having hepatitis B plus D co-infection. This is the phase 3 randomized trial. I think we'll have much more data coming in with this. And this particular drug was quite safe to use also over long periods of time. The next paper that I would like to showcase is again on NAFLD. And I think this is a very interesting and surprising paper, because what the authors did here was to look at biopsy-proven NAFLD patients, and they followed these patients up for 14 years. I mean, you can see the kind of work that they do. I mean, followed up for about 14 years, biopsy-proven NAFLD, and they matched these patients with other population comparators. For example, they had NAFLD and the other group did not have NAFLD, but had other metabolic diseases without underlying NAFLD. And what they found out was that in patients who had NAFLD at the baseline, when they followed them up, they had a higher incidence of severe infections than the comparators. For example, 32%, 32 out of 1,000 person years developed with NAFLD developed severe infection compared to 17 only in the comparator group. And the most frequent infections were in respiratory and urinary tract infections. So if somebody has just NAFLD at baseline diagnosis, then the chances of that person developing severe infections beyond a decade is quite high. Now, one thing that the authors did not look here is that they did not look at how much the metabolic syndromes were controlled. For example, if somebody has an uncontrolled diabetes, that itself predisposes them to infection. So probably it is not NAFLD in isolation, but also the factors that has led to development of NAFLD that has put the patient at risk for developing severe infections. But this is very important because even with simple steatosis and with increasing fibrosis, patients started having higher incidence of severe infections on follow-up. So this is very important. And I think we should all be very proactive in discussing control of metabolic traits or syndromes in patients with NAFLD. This is another important paper, and this is from chronic hepatitis B. This was also published in NEJM. So they have a new drug known as bepirovirsen. So it's getting tougher and tougher for us to actually remember these drugs, but this is also important. So what they did was bepirovirsen is actually an antisense oligonucleotide, and it targets the hepatitis B messenger RNA. So it's very important because it directly acts to reduce all the levels of viral proteins. And it's wonderful because all the antigen proteins are reduced with this particular agent. And what they found out was that it actually reduces even hepatitis B messenger RNA and pregenomic RNA, which is like you want a functional cure versus a complete cure. This is the drug that is going to be. So what they found out was that it did reduce the viral load levels. It reduced the hepatitis B surface antigen levels in about 10% of patients, and they actually had sustained viral response. That is, HBsAg resolved, became non-reactive, and DNA loss was there in 10%, and that was sustained. The only problem is that many patients in the bepirovirsen group developed adverse events. So the adverse events were mostly in bepirovirsen compared to the placebo, but they were not very severe adverse events. They were mostly injection site adverse events, and people actually tolerated it. So we have a drug now which can actually knock out hepatitis B from the nucleus and acts at the RNA and pregenomic RNA level, which is quite interesting and very hopeful for people who are looking to completely clear the virus from their system. Now we jump to alcohol. So I think this study is so important. This study was done by the French group by Alexander Louvet, and this was published in JAMA about a couple of months back, where a very important study, I would say, because so we have steroid treatments for alcoholic hepatitis, which is the standard everywhere. And what happens when you mix, combine steroids with antibiotic? So when this particular study looked at a group of severe alcoholic hepatitis patients receiving steroids, that is prednisolone, along with prednisolone and amoxicillin or clavulanic acid. And what they found out was that the addition of antibiotic, that is amoxicillin acid, to prednisolone did not improve survival in patients. So this was a negative study, but I think it's very important from two ways. One, the addition of antibiotics as a prevention modality of reducing infections when the patient is on steroid, or an antibiotic as one of the agents which can modulate the gut microbiome does not work. That itself is something very important that we need to understand. And the second is that a drug like amoxicillin clavulanic acid is actually safe. So even at some point, I was very scared to prescribe amoxicillin clavulanic acid for advanced liver disease patients, because amoxiclav is the #1 cause of DILI in the United States. That is non-paracetamol DILI in the United States is amoxiclav. So I was I never prescribed this, but look at what they have done here. The French group actually gave this in the sickest group of patients, that is alcoholic hepatitis, and found out that there were no adverse events with giving this drug. So amoxiclav is very safe in patients with advanced liver disease, even with jaundice. So that is one good point that has come out of this particular study. Now, these are two studies which I want to elaborate a bit on. Very interesting, and I think this is the future of hepatology. So you look at your left side. So we can see this is a paper from 2019 Nature by Duan et al. This is from Bernd Schnabel's group in UCSD, University of California, San Diego. So what they found out was that when they looked at the specific microorganisms, gut bacteria in patients with severe alcoholic hepatitis, they found out that there was one particular bacterium which was causing the most significant harm, and that was Enterococcus faecalis. So Enterococcus faecalis was the most upregulated and significant bacterium in patients driving severity of alcoholic hepatitis. And they looked further and found out that the particular Enterococcus faecalis produces something known as a cytolysine. And when the cytolysine levels were higher, the severity of alcoholic hepatitis was also higher. So what did they do? They took a bacteriophage. So bacteriophage are basically viruses that consume or damage or eat up bacteria. So they took a bacteriophage, injected that particular bacteriophage which consumes Enterococcus faecalis, and they found out that when the bacteriophage was injected and these patients were followed up, the Enterococcus faecalis levels reduced, the cytolysine levels reduced, and the severity of alcoholic hepatitis reduced. So they did this study in humanized mouse models, and this was excellently done because there is some role of phage therapy in management of alcoholic hepatitis. Now let us go to the other side. So this is another group, a Chinese group. So what they did was similar to what the other group did in alcoholic hepatitis. They looked at specific microbiota in NASH, that is metabolic associated fatty liver, non-steatotic hepatitis, that is NAFLD related, non-alcoholic. And what they found out was that in this particular group, Klebsiella pneumonia, a particular strain of Klebsiella pneumonia known as the H1A1C, that is H1A1C strain of Klebsiella pneumonia was the one which was causing severity of NASH in mouse models, which was also seen in human models. So what did they do? They did the same thing the other guys did. So they purified and retrieved bacteriophages which will specifically attack that particular Klebsiella pneumonia strain, and they gave it to these mice which have severe non-alcoholic steatohepatitis, and found out that when this phage therapy was given, the levels of these particular Klebsiella reduced, and the non-alcoholic steatohepatitis actually reduced even histologically. This is fantastic. So there is a role for precision medicine by targeting specific microbiota, bacteria or group of bacteria in treating alcoholic versus non-alcoholic steatohepatitis. And this second paper was again published in Nature, and this was from Gan et al. So I think not just those other drugs that we have seen before, phage therapy is also an important upcoming treatment for alcoholic hepatitis and non-alcoholic steatohepatitis. And I think it's not one size fits all. We treat HIV/AIDS, and like we treat tuberculosis with combination drugs. The treatment of alcoholic hepatitis and MASH in the future will be with combination therapies. So we'll have a phage therapy in between. We'll have some particular drug that we discussed before, and we'll have some lifestyle changes, and so many things come together. And that is how we have to deal with treatment of these two disease conditions. And it is never a single drug. And that is where we are improving ourselves on regarding this particular treatment. Now, this is a very depressing paper. I read this and I was quite terribly depressed looking at it. So what this particular study looked at was they looked at children of parents with ALD and AUD. So ALD is alcohol associated liver disease and AUD is alcohol use disorder. So the children of parents with alcohol-related liver disease had up to more than 4-fold increase for alcohol-related hospitalization, even in the absence of alcohol liver disease. So what happens is that if a child has a father with alcohol liver disease and alcohol abuse, the chances of that particular child or the teenager or the offspring to get hospitalized because of an alcohol use is about 2.1. That is the risk ratio. If the mother has alcohol-related liver disease, then it's similar to the father, that is about 2.1. But if both parents have alcohol use disorder and is having alcoholic liver disease, then the chances of that child getting hospitalized and going for alcohol use disorder is about 4.4, which is quite bad because you look at what alcohol does to people. It just destroys boundaries even within the family. So this is very important for us to discuss from patient perspective. Tell them that their children are also at risk of developing alcohol related hospitalization if the parents are continuing or diagnosed with alcoholic liver disease. This is a very interesting paper, and this is from China. And this looked at the specialty of the Chinese population is that there is a lot of stroke and intracerebral hemorrhage in China compared to other countries. So this particular group of researchers, what they did was they looked at what was the additional risk factor that these people have. Why are Chinese getting more of hemorrhagic stroke or bleeding, intracerebral bleeds compared to people in other countries? And they found out the answer as hepatitis B infection. So Chinese population are the highest when it comes to prevalence of hepatitis B infection, and patients with hepatitis B virus infection have a higher risk of developing intracerebral hemorrhage, but not ischemic. So ischemic stroke is mostly for metabolic diseases, but intracerebral hemorrhage is mostly for chronic hepatitis B virus infection. And this is something the Chinese group identified. So somebody has hepatitis B virus infection, please remember that the chances of them developing an intracerebral hemorrhage is quite high. This again, like the other alcohol study and the children study, this is also depressing because see, we are so happy with direct acting antivirals. So when you give direct acting antivirals, we are like happy that they have sustained viral response. It's so easy to treat hepatitis C. But what this particular study showed was that even after completely curing the patient of hepatitis C, that is, there is sustained viral response over many years. That is, this particular study looked at a follow-up of 6 years. And patient had compensated chronic liver disease. What they found out was that even after the cure from hepatitis C, the risk of hepatic decompensation and the risk of liver cancers was still high. So about 4% of patients, that is about 1 in 10, that is 1 in 10 patients with advanced liver disease with an hepatitis C cure can still develop complications related to decompensation and liver cancer. And I have put this particular picture here for you to understand what is a compensated advanced chronic liver disease. So when you look at the fibroscan, so the fibroscan is about 20 kilopascals. That is an advanced chronic liver disease stage. That is CACLD. That is as per the Babino, latest Babino guidelines. And if it goes above 25, that means that this patient has advanced liver disease plus clinically significant portal hypertension. So in the CALD group, CACLD group, that is compensated advanced chronic liver disease group, there is no significant portal hypertension. But this group of patients, even with an hepatitis C cure, can develop, 1 in 10 of them can develop decompensation and liver cancer, and they need to be followed up and they need to be under surveillance as per standard cirrhotic protocols. So please don't think that after driving away hepatitis C, things are all fine. If they have underlying compensated advanced chronic liver disease, they are still at risk of developing advanced liver disease events and also liver cancer. Another very interesting study where a group of patients with moderate to severe liver disease was taken. That is Child-Pugh score 7 to 10. And a group of them were given rivaroxaban. So rivaroxaban is an anticoagulant and it blocks the factor 10A activity. So what the authors hypothesized was that if you block factor 10 activity, the hepatic stellate cell activation also reduces because factor 10 is an important aspect in activation of hepatic stellate cells. And that actually reduces the vascular, microvascular complications and fibrotic complications in cirrhosis. So what they did was they gave a group rivaroxaban and they gave another group placebo. And what they found out was that when they looked at these patients over about 24 months, that is about 2 years, they found out that the patients who were receiving this anticoagulant, they had lesser development of decompensation and higher survival without transplantation. Fantastic. This is a fantastic paper. So what you do is when you have patients with advanced liver disease, say child 7 to 10, and you want to actually reduce the chances of decompensation or increase the transplant-free survival, the use of an anticoagulant like rivaroxaban may actually help. So this has to come into recommendations, but this study is the start of something new in the future for management of liver disease per se from a general point of view. This is also a very interesting study that I found very useful. I just love this study because this is something I used to do. Because we do get a lot of patients with autoimmune hepatitis, right? And our go-to drug as per all the guidelines is azathioprine. So we have steroids with azathioprine. But a lot of patients in my practice don't tolerate azathioprine well. So some of them develop pancreatitis, some of them develop leukopenia, cytopenias. Some of them are intolerant. They have a lot of gastritis issues, vomiting. So for such patients, I used to give mycophenolate mofetil. And at some point, I realized that, people are actually tolerating MMF much more than azathioprine. I started giving everybody MMF and I stopped using azathioprine at some point. But then this study actually proves that if you give mycophenolate mofetil compared to azathioprine as the first line of treatment, that is in treatment-naive patients with autoimmune hepatitis, then they developed biochemical remission far better. That is, mycophenolate mofetil with prednisolone was far better and superior to azathioprine with prednisolone in the treatment of treatment-naive autoimmune hepatitis. So that is 56.4% versus 29%, which is excellent because the only catch is that MMF is expensive. But the other catch is that you don't have to monitor it so much. And you can increase the dose and patients are very comfortable with tolerating it. So I think this is a good study where we'll see that mycophenolate may become the go-to drug for treatment-naive patients with autoimmune hepatitis. The next study is on ACLF. And I think probably this is the only study I have put up for ACLF. This study is something very important and interesting. I'm not sure how much practical this is. So they made a new liver dialysis device known as DiaLive. So this is by Rajiv Jalan's group. And what they did was that they looked at treating patients with ACLF class 1 to class 3A. So class 3A and 3B, please remember this. This is something that you might not know. So ACLF with 3 organ failures is ACLF 3A. And ACLF with 4 to 6 organ failures is ACLF 3B. So we have ACLF class 0, 1, 2, 3, right? So inside 3, you have 3 and 3B. 3B is the worst of the lot because they have very high mortality. So they did not take 3B in this particular study. They took up till 3A. And what they did was that in this particular study of DiaLive, they found out that patients had significant reduced time to resolution of ACLF, and also the prognostic scores like the CLIF-C score, CLIF-ACLF score, the mortality at 28 days, all of this actually improved with DiaLive compared to standard of care alone. So what DiaLive does specifically is it works on albumin and endotoxin. So there are specific filters which removes PAMs and DAMs. So the pathogen-associated molecular patterns and damage-associated molecular patterns, that is endotoxin and dysfunctional albumin, it acts at that particular level and acts as a dialysis machine. Works like your classical Mars and Prometheus, but has a different set of combinations and ports. And this actually improved ACLF. So we may have something that we can intervene in patients with ACLF, which is also higher grade of ACLF like 3A, to increase the transplant-free survival or improve the bridge towards transplantation. Now, another study which we very commonly use. So I have not done a TACE procedure for my patients in the last 2 years because I have this particular luxury, I would say, at Rajagiri for SBRT. So that is stereotactic body radiation therapy. And it's very interesting because it's very well tolerated. It is done on OPD basis and it's not very expensive like we have for TACE and all that. and tear. So what this particular study did was they looked at patients with very advanced liver disease, that is child-pugh class A and B, with metastatic liver disease and with tumoral thrombosis. So basically we could not offer them TARE, or we could not offer them TACE or RFA or microwave ablation or even transplantation. And such patients, what they did was they put one group only on sorafenib and another group on sorafenib with SBRT. So SBRT can be done in advanced liver cancers. It's very interesting. Even with very high level of advanced level of microvascular invasion, we can do SBRT. So when they looked at patients with SBRT and sorafenib, they found that the median overall survival and the median progression-free survival was much higher with patients on SBRT and sorafenib. Very importantly, patients were downstaged better with the use of SBRT and sorafenib rather than sorafenib and SBRT, rather than sorafenib alone. So please note that if you have patients in your clinical practice where you are looking at BCLC and you are stuck with just the medical therapies and pharmacotherapies, please remember that SBRT, even though it is not coming to guidelines, but I'm sure it is going to come very soon because it is already in Japanese guidelines. It is a fantastic modality. It just melts away the tumor. Absolutely no side effects to the patients as much what I have seen, except for large tumors where they can develop some tumor necrosis related side effects, but otherwise well tolerated by many patients, even the elderly. SBRT actually improves downstaging chances and also improves overall survival and progression-free survival in advanced liver cancer. So this is something new that will soon come in Baveno, your BCLC guidelines also. Now, very interesting drug. I'm sure you have heard about semaglutide. It's all over the news. Ozempic is the name. And what Ozempic did was, so when in the US they studied this particular molecule, they found out that this not only improved diabetes, but also reduced weight. So this was like a wonder drug, a magic drug, where people could also lose weight without exercise. And Ozempic was a big hit there. So what did Rohit Lumba's group do? What they did was, this came in Lancet Gastroenterology Hepatology. What they did was they gave semaglutide in patients with NASH related cirrhosis. And this was a phase 2 trial, and they gave another group placebo. And what they found out was that, just like what they found out in other studies in diabetes, many patients, on a large proportion of patients on semaglutide actually lost weight, and they lost a good amount of weight. But the anticlimax is that that weight loss did not translate to fibrosis regression. So there was no change in fibrosis or no regression in cirrhosis, even with that weight loss, even though that weight loss led to improvement in cardiometabolic parameters, and also a lot of non-invasive fibrosis markers and liver injury markers actually reduced. But it did not translate to improvement in cirrhosis or fibrosis grade, which is actually a kind of a bummer moment. I mean, it was anticlimax for me, if you ask me, because even though weight reduced, the fibrosis did not. But to play the devil's advocate here, this study was very small numbered study. The sample size was small and the follow-up was also quite small. This is just at 48 weeks. So if you maybe look at 72 weeks, you can actually see improvement in fibrosis better, maybe. So I think we need to work on this molecule more, because I think this molecule has a great potential in management of NASH-related cirrhosis, especially in patients with obesity and diabetes. Another new drug, I'm not sure if you have heard of it. This is the first time I'm seeing this. This is known as larsucosterol, and this is for severe alcoholic hepatitis. And what larsucosterol is basically an endogenous sulfated oxysterol, and it is an epigenetic regulator. Right. So, I mean, I'm not going into basically not going into more details of that. But what epigenetic regulators do is that they modulate gene expressions within the nucleus of the cell without altering the DNA sequence. So what they do is they modulate the gene expression within the nucleus without altering underlying DNA sequence. So these are like really much into the future kind of molecules we are now dealing with. So what they did here is that when they gave larsucosterol for patients with severe alcoholic hepatitis, they found out that, one, it is safe. Patients tolerated it very well. And second, patients actually survived. Even though the numbers were small to look at significance, a larger proportion of patients survived when they were on this particular larsucosterol. And it was just an infusion about 72 hours apart. And most important is that biochemical parameters improved, but we don't know what is going to happen to the clinical parameters because it was just a safety and tolerance study. So I think this molecule also will have some value in the future for the treatment of severe alcoholic hepatitis. I'm not sure how the cost is going to be because it's such a futuristic deadly molecule. And I think we need to have more studies on it. Very important. So this study, what happens is, all of us will agree that even I used to do this. As decompensated patient comes to the emergency, what do you do first? You give them ceftriaxone, like they are deficient in ceftriaxone, right? So everybody gets a cefiperazone or a ceftriaxone. Some even get piperazine tazobactam the moment they land up in the ER or they get admitted. So does that help? So this particular study, what they did was they looked at patients from the entire trial, and they looked at all the patients who received empirical antibiotics at admission, decompensated patients, versus those patients who did not receive antibiotics at decompensated patients who did not receive antibiotics at admission in the ER or in the wards. And what they found out was that there was no difference at all in hospital-acquired infection or mortality. So basically, just giving antibiotic the moment patient lands in the ER or gets admitted does not work out for the benefit of the patient. And in some of the patients, that is, when the decompensations were severe enough, the use of antibiotics in the absence of infections actually led to more mortality. So this is also not good news. So if you look at this particular data here, this in yellow here. So patients given long-term antibiotic prophylaxis at discharge had no differences in 6-month mortality compared with non-antibiotic patients. So there is no point in just giving an antibiotic to a patient, especially decompensated cirrhosis patient, the moment you see him in the emergency. So if at all you want to continue antibiotics, please make sure the patient is infected and there should be documented infection. Otherwise, please stop antibiotics.
काय माहिती काय फायदा नाही म्हणतात.
This is my last slide, and this is completely different from what we spoke about. This is just for a lighter moment for all of us, because I'm sure you'll be tired after listening to a lot of those new studies on new molecules. Very interesting. So this is about Beethoven. You know, Ludwig van Beethoven is a very famous musician. When he died in, I think, 1867, he had hearing impairment. So he had progressive hearing loss, and he had a lot of issues. He had diarrhea. He used to have a lot of GI problems, and ultimately he died of jaundice because his autopsy actually showed that he had underlying liver disease and he died of jaundice. Now, how did he die? So Beethoven never knew what he died of. So what he did was that he wrote letters saying that after his death, somebody should find out what he died of and should make it public. So this became one of the biggest, most sought out medical mysteries in the world ever. How did Beethoven die? And ultimately what happened was that based on a lot of exhumations, bones and all that collected from Beethoven's gravesite, and also some of these hair locks, see this. So a lot of private collectors and public collectors collected Beethoven's hair, and they keep it in their own private museums and all that. So a lot of these hair strands were available. About 8 locks are available by different collectors. So what one group identified was that in one of those locks of hair, there was high levels of lead. So the cause of death, they said, was that it was because of lead poisoning. So basically what happened was that at that time, doctors, when they used to clean wounds or give some solutions, it was all based on lead salts. So lead salt poisoned Beethoven, and Beethoven ultimately died of lead poisoning is what the original thought was until now. So this came in 2023, and this is a fantastic paper which was published in Current Biology, where a group of researchers, archaeology and molecular biologists, they looked at all these hair strands, the 8 locks of hair, and they did something known as a genomic analysis based on an ancestral DNA data. So we have a lot of ancestral DNA database now because of a lot of these companies checking DNA and telling people how their gut health is, how their other health is, how their organ health is. We have a lot of people submitting DNA for analysis regarding their ancestry. So we have a large database of ancestral DNA data. So what they did was they ran all these hair DNA samples through that particular ancestral database and found out that 3 hairs did not belong to Beethoven. 5 of them belonged to the same European ancestral category of a male. 3 of them did not. Out of that 3, 1 was actually from a woman from Jewish descent. And that was the hair which contained lead, which means Beethoven did not die of lead poisoning. That was some other person's hair. So now they are stuck with what actually killed Beethoven. So what they did was they did whole exome sequencing and found out that Beethoven had two types of liver disease related mutations. So one was PNPLA3, that is your patatin-like phosphatase, which is very commonly seen in fatty liver disease. And the second was HFE mutation, a variant of HFE mutation. So he had two, that is HFE and PNPLA3, which are well known to cause cirrhosis. But then they were actually heterozygous. So what was the driving factor? Then they looked at all the letters that Beethoven has written and found out that he was actually an alcohol user. And he used to drink a lot of alcohol. Even though they claim it is modest, alcohol in the presence of these heterozygous mutations are found to cause cirrhosis. Very interesting. So HFE mutation with PNPLA3 mutation, just based on hair strand analysis and the presence of cirrhosis on biopsy, proved that Beethoven died of cirrhosis due to these mutations plus alcohol. But there was one very interesting googly there. One of the hair strands, which was recently collected, actually showed the presence of hepatitis B virus infection. So ultimately what happened was that at the time that Beethoven died suddenly, he had severe jaundice, which means he had a reactivation of hepatitis B possibly at the time. And because he was already having underlying cirrhosis because of two genetic mutations and use of alcohol, the hepatitis B reactivation actually killed him. So the reason why Beethoven died is because of alcohol and hepatitis B, which was driven by HFE and PNPLA3 mutation. Wonderful, wonderful medical analysis in hepatology based on the sharpest of tools that we have, that is genomic analysis. And I think this is going to change the future of hepatology management, because now when you look at management of hepatocellular carcinoma, you look at management of alcoholic hepatitis, you look at management of NASH or MASH, the genomic analysis and landscaping of genetic profiling and epigenetic profiling of all these diseases, we will have much more to target in these patients. And this is going to become a great great weapon for us to treat patients of cirrhosis in the future, liver disease in the future. And I would like to end by one big climax from this particular research study. So while they were doing and understanding, how Beethoven died, they found out something else. So Beethoven's father, so that his name is Arwen van Beethoven, they found out that the Y chromosome was not from him. It was from somebody else, which means that Beethoven's mother actually had an extramarital affair. And Beethoven is actually not Beethoven, it's somebody else's son. So that also they identified on this particular analysis, that Beethoven actually was not really born from Beethoven family. It was from some other family, and there was an extramarital affair. So I would like to conclude my session here, and I would like to hand over to the moderators and the chairpersons to please take over. Thank you.
Thank you, Dr. Abi, for a wonderful discussion on varied topics in hepatology, including the genomic studies of Beethoven and how this disease manifested with a flare of hepatitis B. Dr. Varghese Thomas, can we have another 15 minutes for discussion?
Definitely.
Any questions from the students?
There's only one question in the chat box, so there are one or two. The one, Abhi, can you just open the chat box and?
Yes, sir. I've got it. So there was one question. Can we use rivaroxaban to reverse decompensated state? So that particular study actually showed that rivaroxaban use reduces the chances of decompensation. It does not mean that you can actually reverse the decompensated state. So this was basically used in patients who were already on treatment for decompensated cirrhosis, child 7 to 10. And when they were given rivaroxaban, it prevented further decompensation and reduced improved the transplant-free survival. So the whole aspect of decompensated state just does not independently rest on rivaroxaban use, but also other measures, for example, beta blockers and diuretics, etc.
So there is one more question from Saji, that any development for the use of aptens in refractory ascites?
So the aptens So what Vaptans do is that they will definitely improve the sodium status. So you can correct hyponatremia with the use of Vaptans, but it does not clinically translate to improved clinical outcomes. So that is what all the Vaptan studies have shown. So if you give Vaptans, tolvaptan, and you raise the sodium from 120 to 135, that does not mean that patient is going to improve clinically. I mean, any clinical event is going to improve in the future. So it is just for the sodium correction it is used. Otherwise, it has no clinically translatable benefits.
Now,
There are
one
two
more
more questions. Two more
on
questions.
FMT, protocol on FMT, and then your comments on current indications for FMT.
So the protocols are not standardized because FMT is still a research protocol. And I mean, the protocol that I use here and the protocol that ILBS use and the protocol that PJ Chandigarh use, very different. So I use a nasoduodenal protocol. PJ Chandigarh uses a rectal enema protocol, and ILBS uses an endoscopic protocol. So it differs. So there is no standardization. But whatever the studies have shown is that independent of the mode, the route of administration or the duration of administration, the outcomes were almost similar. We don't have a meta-analysis of this, but there is a meta-analysis coming up. There is a group in Mayo doing it. And I think we'll have some better idea of which route and which duration of therapy will be useful. But at the moment, we have no standardization.
What about the concept of recompensation? I don't really believe that the recompensation lasts for a longer period of time. What is your view on a recompensation?
So I think recompensation is something that we can speak to the patients about. I'm not sure if recompensation really has an impact on the natural history because that is driven by so many other factors. But recompensation definitely has an impact on the patient because that helps the patient to be motivated and stick with the treatments at end. For example, the most important aspect of recompensation is in alcoholic hepatitis. Patients who develop alcoholic hepatitis and ACLF, when they stop drinking and you give them targeted treatment, and if they continue to stop drinking and remain abstinent, they have very prolonged transplant-free survival. So in that sense, I think recompensation is useful, but from a natural history point of view, I'm not very sure.
There's a question by Dr. Saji. Is bulevirtide acting by blocking entry of Hep B?
Yes, bulevirtide is actually a direct acting agent.
So one of the drugs which you mentioned was the one which actually probably will also stop producing hepatitis B herpes antigen also. That's a concern for many people going to Gulf and other countries. You know,
Yes.
we were always
Yes,
at a loss to have to stop the HBsAg production. So probably that
Yes,
will
sir.
be
That is bepirovirsen. That is the drug, but
all
it's an
tongue
injectable
twisting
drug.
drugs. Yeah, all tongue twisting drugs. Names are very difficult. Jayati ma'am, your comments?
I was just admiring and just listening. Thank you so much, Philip, for that wonderful update. It was really wonderful. I mean,
Thank you.
Maybe one or two have come across, but almost all were just most updated. Thank you very much.
Yes, thank you.
There's a question on MASLD. And Abhi, there was also some mentioning that is a communication, no? Met ALD, no? That's what we should use. Yeah. Combination.
So so that is this particular slide, sir. This particular slide, which shows that depending on the amount of alcohol consumed weekly versus daily in males and females, you have a spectrum where there is only MASLD, and then the other end of the spectrum is ALD predominant MASLD. That is your Met ALD. And if it goes beyond that, then it becomes PACA, full form ALD.
So that means they should have some of the features of metabolic syndrome plus alcohol in 50 to 60 grams per day. Okay.
Yes, that's right, sir.
Dr. Abhi, we are changing the term NAFLD to MAFLD and other things. But when it comes to ALD, is there not a taboo also? You are taking alcohol liver disease to a person who has been drinking. I think the changing the name does not take away the basic spectrum of the disease. I think it is a group of hepatologists who wanted to bring something so that the field is growing. I don't think it serves any purpose at the end of 2 years from 2020 to 2023. I think still we use the taboo word alcoholic liver disease. We have to find a new word for alcoholic liver disease. If there is something called a taboo with the word alcohol or with the word fatty. Your views?
Yes, sir. Sir, this term of alcoholic, what ASLD mentions is that it should be alcohol associated liver disease, not alcoholic liver disease. Similar to, we say alcoholic hepatitis, it should be alcohol associated hepatitis.
But still there is
And-
a word alcohol.
Yeah, I mean, the etiology, I'm not sure how much we can modify there, sir, because in patients with non-alcoholic fatty liver, I mean, they are not even consuming alcohol. So why bring in the word in the first place? So that was the critique.
No, they are consuming alcohol. See, when you say non-alcoholic, you have given the earlier definition of less than 20 grams, which means they may be still consuming alcohol.
Yes, they'll come under met-ALD.
No, what I am telling is, when you have an alcohol with any quantity, it is dangerous, whether it is 20 grams or less than 20 grams.
Yes, yes, sir.
When you use the word alcoholic liver disease, I think still there is a taboo. I think it is a gimmick of hepatologists, very frankly speaking, which I think is not taking the field forward, but it is just trying to have a few things charted out for 1 to 2 years.
True, sir. I mean, I agree with that.
There are some more questions in the chat box, Abhi. And that's a question on
So
single.
there is a
Yeah.
question on there is a question on single lesion HCC with more than 10 centimeter. See, I mean, I think we need to have a lot more data on that, because if it's a single lesion HCC more than 10 centimeter with a very low AFP without any macrovascular invasion, fairly preserved liver functions, I would definitely opt for a liver transplant, because it can come in beyond Milan. But if there is a very high AFP and we need to downstage this patient, I would either choose a TACE procedure or an SBRT, because we do SBRT in large HCCs, even with macrovascular invasion. And that helps us downstage this patient and then shift to a transplant scenario. So ultimately, whatever we choose for our patients with HCC, we look at if these patients can be cured with a transplant at some point, except those patients with BCLC-C and patients with metastatic liver cancers, where we cannot offer much from curative point of view. So I think just by that lesion size, we can't take a sure shot decision. I think there should be a lot more data available for us to make a proper approach to that particular patient.
But do you think that a 10 centimeter lesion, if it has got a low AFP and you do any other procedure by downstaging, you take it up for any other specific procedure, will it have a better survival?
So definitely. So there is this data from Busan, from the Korean group, where they have shown that downstaged HCC patients, who undergo liver transplant versus just downstaging and medical management, actually they have a better better survival than those who are only on medical care. So this is a very, at least in Southeast Asian countries, this is a very commonly followed norm, where they downstage and then take for transplant. But if they have a baseline very high AFP, then things change. Chances of recurrence of HCC in the graft is also very high, even if it is fully downstaged.
Some more questions.
Varghese
Yes.
Thomas?
Yeah.
SBRT, just one session or multiple sessions, Abhi?
Pardon me, ma'am, the downsstaging.
Yeah, but downsstaging, especially those with portal vein thrombosis and all, is it just few sittings or one sitting or?
Ma'am, if it depends on the type of modality intervention that we use. So, for example, if it is a TACE, some operators do staged TACE, because it won't cover the whole 10 centimeters, the lipidiol and the chemotherapy mixture. But if it is an SBRT, we can cover the whole 10 centimeters with a radiation.
So how many sittings generally? How many sittings generally?
Five sessions, yes. Low dose, 5 sessions. Generally.
Yeah, today SBRT is making a major impact, and in fact, no case of HCC is turned back without an SBRT.
Yes. I mean, we have fantastic. I mean, we would wish to publish it sometime next year. We have very good data on large number of patients on SBRT. I mean, I have not done TACE for about 2.5 years now. Just SBRT. Fantastic.
Any new changes in the ACLM guidelines in ESL?
No, I mean, guidelines are all the same, but a lot more on pathogenesis and gut microbiome related data are coming up in ACLF. But and also a lot more data on transplantation. High grades of ACLF, they fare much better with transplantation than without. So such data is also coming up.
There's a question regarding phage therapy, indications and practical applications. So, it's very
Currently,
experimental, no? Very experimental.
currently, there are no indications for phage therapy. I think there was one. I mean, I think the largest numbers of phage therapy studies done is in sepsis. For example, especially in MDR and XDR related infections, they have given phage therapies to tackle MDR infections. And there are some studies on that. But otherwise, from a hepatology point of view, it's purely research based because phage therapy, to isolate the particular phage itself, is very expensive. And it's not yet commercialized at all.
The question from Joe, he has asked, why could be the children of ethanol use parents have increased ethanol-related hospitalization risk? Is it genetic or environmental or due to cohabitation or behavioral, something like that?
I think all of those points work out. So they definitely do have a genetic predisposition. Environmental impact is there, cohabitation is there, and behavior influence. And I think all of this work together to impact the offsprings to take up alcohol. And the reason for hospitalization is not because of liver. That is the most important in that particular study. It was non-liver related causes. For example, blackouts, suicide attempts, vehicle crashes, accidents, and things like that.
Your study regarding the sleep and HCC, no? Is it that people with advanced disease may be having either inversion of sleep rhythm or prolonged sleep due to drowsiness, and that indirectly reflects upon their risk of severe liver disease and HCC?
Yes, I mean, I would definitely agree with that. If that was controlled for, I'm not very sure. But what they have done is that they have enrolled patients who did not have any decompensation at the baseline. Just the ones who are napping in the morning versus those who are not napping in the morning, and those with poor sleep at night versus those without poor sleep at night. And I think that was a pretty well matched cohort. And in them, in the long term, they have identified this. But definitely, I'm not sure how much of liver disease severity was there in those particular group of patients. And I think I need to read on that a bit more.
Okay. Regarding this Dialive by Rajiv Jalan group, how do you compare with our Plex, which is our 4 months liver dialysis, Plex therapy?
I think Plex therapy, it's pretty much. I mean, there are no good quality studies on Plex, to be honest. But whatever studies that we have, when we looked at all the, I mean, there are some systematic reviews on it, which shows that Plex therapy does not work in alcoholic hepatitis. All the more, especially if the patient has alcoholic hepatitis in a higher grade of ACLF, for example, ACLF 2 or 3A. 3B is absolutely out of the question. It worsens the outcome. So such patients don't do well with Plex. I mean, personally, I have stopped doing Plex since probably 2019. I have not done any Plex in alcoholic hepatitis.
Regarding that intrahepatic hypothyroidism in FL, are there any insights into that? Why it happens actually when the thyroid profile is normal in the serum, but only inside the liver there is a hypothyroidism? Any idea on that?
Sir, that I'm not sure if that has something to do with dysregulated metabolism of thyroid hormone, specifically in the liver microenvironment. That I'm not very sure. I mean, exact signaling pathways, I'm not sure, but I think it is something to do with purely the liver microenvironment because of dysregulated blood flow, presence of fibrosis, presence of a localized inflammatory milieu there.
Okay, I think we had a very exhaustive session. For the comments by Shanai sir, Jayanti ma'am.
No, I think we have to thank Dr. Abhi for taking his time and enriching us with the recent advances in hepatology across various aspects of liver disease. A big thanks to Dr. Abhi from our group.
Thank you, sir. Thank you for giving me the opportunity also.
And all of you can give a big round of applause through your reaction box you can show the reaction, or only few of us are on the video. Okay, but I am sure Dr. Abi would have spent lot of time making the wonderful slides, and slides are also equally beautiful and simple, and showing lot of diagrams. So I'm sure you'd have taken such a lot of time to prepare this, and they are very current because ESL has happened last month, and the data is also very current, and most of these things would not have come in print also. So the students will be extremely happy because these are fantastic, wonderful information. I was just awestruck by listening to all the new drugs and developments. So, Jayanti ma'am, your final comments.
I have to just say thank you. It's so difficult for people like us to update, and I do not know, some of these never get updated even in the conferences that we attend, we keep hearing the same thing. So I think thank you, Avi, and a big regards to your dad. Okay.
Okay, so
Yes,
on
thank
behalf
you.
of ISC Kerala chapter and on behalf of all the other faculty members and all the students, I say a big thank you to Dr. Sirek Abi Philip, who has done a great job.
Thank you.
Thank you, sir.
So,
And good night.
hats
Thank
off
Good
to
night.
you. It was a great
Do
job.
well. Do well, Abhi.
Good night.
Thank
Good
you.
night. And we will. Okay, the recorded version will be available and it will be posted soon. The link will be posted soon. It is already there in the Facebook. The videos will be available. Okay, so I am signing off.
Good night.
Good night. Good night.